Good morning, everybody. Welcome to the NSPA's webinar, Self-Harm During COVID-19. I'm Penny Foston. I'm the Executive Lead of the National Suicide Prevention Alliance. We still have people joining us, but there are a few things that I wanted to just say before we get into the presentation. So I'm really delighted that so many people were interested in this subject. It's been astonishing to see over 500 people registering to join us today, and I'm really glad we can be meeting the need that there is out there. We'll be hearing from Keith Waters from Derbyshire Healthcare NHS Foundation Trust and the Multicentre Study of Self-Harm, and Claire Dixon, the Training Services Manager and Trainer from Harmless. We thought Caroline might be joining us, but Claire is also excellent and extremely knowledgeable and informative. So just to talk a little bit about why we're running this session. So quite early on in lockdown, the NSPA began running online conversations. So just bringing people together, creating a space to say, what are people worried about around suicide prevention, self-harm, suicide bereavement during lockdown around this whole situation. And we had some quite broad ones, and then we got into more specifics subjects, so reaching and supporting men, children and young people, older adults, mental health service users, and people who self-harm. And that was really well attended. There was lots of interest in that online conversation as well, and really important issues that people were bringing up. So there was some conversation about who people are thinking about when we're talking about reaching people at risk of self-harm. So often people are thinking about young people, but actually lots of organisations part of that conversation were saying people of working age and older adults are also at risk of self-harm. So that was really important for people to be thinking about, particularly when we had the conversation, it was in June, and there was real awareness that for all sorts of health conditions and issues, people weren't presenting to hospital in the way that they normally would, with the whole protect the NHS, stay home message. And that was also affecting people who may have injured themselves. So that was a concern for people. Some of the services that we were talking to were aware that people who had previously been in recovery and hadn't self-harmed for quite some time were getting back in touch with services and asking for help. So that was a concern for people. That there was lots of anecdotal evidence, but not as much data as people would have liked about the real need out there. And also, there were some really fantastic projects and plans and ambitions and ideas that people were sharing. So that was a really important conversation. Let me just put into the chat. We wrote up a summary of that. And it's, dear. I'll find it and put it in the chat when I've finished speaking, so that you can all find that as well, because I think there's lots in there that will also be useful and interesting for people. So we'll be hearing the two presentations. Just to say that Keith is currently on a canal boat, and therefore, because he's a little concerned about his internet connection being a bit more dodgy than some of us are in our homes, he's pre-recorded his presentation, but he is here and he will be joining the Q&A later, assuming all stays stable with his internet. We're recording the session, and afterwards we'll be putting it on our website. We'll also be making both the shorter presentations available as separate videos. One of the things that I think it's really important to say is that this can be a difficult subject. Some of us have been personally affected, some people are working in this area, but please look after yourselves. If some of the stuff that we're talking about here feels like it's hitting a tender spot, or it's affecting you more than you thought it might do, feel free to just dip out and come back and watch the videos once they're on our website. We'll be emailing all of you with the link. And also, if you have found anything distressing, please do call Harmless, get in touch with Harmless, or call Samaritans, or reach out to a member of your own support network and have a conversation with people. It's really important that we look after ourselves, because we are still in this strange COVID time and we need to be taking care of each other and ourselves. A couple of bits of housekeeping. You'll see that we have the chat box, which people are already using, which is fantastic, to say hello, maybe make comments on the presentations. If you have questions, there is a separate Q&A function. Please do put questions in there. and then we'll be using that for the Q&A later. And if there are quick questions, we might be able to send an answer more immediately. So please do use the Q&A section. Now, we've also got a little poll, so I'm going to ask Emma in the background to launch the poll just to find out which sectors people have come from. So we've got over 300 people now. So please do just let us know which sector you're from or where you're calling from. Gosh, loads of you, brilliant. So I can see we've got quite a lot of people from the NHS, from charities, from kind of local government and public health. Lovely, lots of academics and students joining us today, so that's fantastic. Really good. Gosh, isn't that really interesting? Good. I'll just give you a couple more seconds to fill that in. We're up to 337 people in the webinar now. Great. Emma, do you want to just shut the poll and we'll show everyone all of the information? So this is a great cross section. I'm sorry that some of you didn't get to see the poll. That's a shame. I hope that you feel that you are represented in the numbers that have been put in here, but you can see we've got lots of people from the NHS and from charities and from local government, and then again some students. So we'll bear that in mind as we go through the presentation. Great, thank you very much. Let's stop sharing those results, and we'll begin. I'm delighted to introduce Keith Waters, and as I said, it's his presentation is on video, so that will be starting shortly.
Hello and welcome to Narrowboat Still Waters. For this presentation, I'm actually going to record it, basically because I'm on a narrowboat. I'm just concerned that on the live event, if there's an internet related problem, there may be some difficulties. I am planning to be with you on the day, but I wanted to record this session before the actual day, just to cover any potential glitches that may be present. So we're going to talk about COVID-related self-harm situations. I want to give special thanks to Phyllis and Jessica, who are part of the Derby part of our study team that have helped put together this set of slides. So we're going to rely for this presentation on details predominantly from the Multicentre study of self-harm. Most of the things I'm going to present to you will be stuff that we already knew or have known prior to the onset of COVID, but something we need to really remember, that we shouldn't ignore what we already know, and we should make sure that we're doing the right things because we knew that that's what was the case prior to COVID. However, we're also mindful that the COVID has changed many things. Some of the things that we did anticipate or expect haven't always necessarily occurred, i.e. the uptake of health care resources has not been the same as it was prior to the COVID situation. So what is the Multicentre study of self-harm? Basically, it's the coming together of Oxford, Manchester and Derby to share their data on self-harm presentations for well over 10 years. And this therefore gives us a huge database of information in order to start to explore a lot of the factors that are there and to find out sometimes new and innovative ways that we can understand what self-harm is about and ways in which it can be helped and effectively be cared for. So what do we look at? We basically look at every self-harm presentation that occurs through the hospital doors. Predominantly that will be the EDD department, but not exclusively so. And we'll look at a whole variety of factors in order to help to understand what this self-harm presentation is about. So it will be things like epidemiological, the causes of the self-harm, the clinical management issues, outcome as well as prevention. But why is this important? Well, it's important to know what's causing people's distress and despair and what might be helpful to alleviate that. But also we know that self-harm does bring about premature deaths as well, not necessarily inevitably from future self-harm acts or suicide, but actually in terms of reducing life years. And those who self-harm can be expected to live fewer years than those that have not. So in itself, that's just a really key important message that's there. Where would we be in presentations without an iceberg model? Well, here's our iceberg model, and basically it highlights the fact that the number of suicides are relatively few compared to the number of people presenting to services. That's predominantly will be hospital services, but in fact the total number presenting to the community will be much greater than that's seen above the water. This might still be the case with COVID. We don't know. It's possible that those in the community may be greater, but our current information is showing that those presenting to hospital decrease rapidly and hasn't yet picked up to the level that was there. Neither have we been able to establish yet that the suicide rate will inevitably be rising because of the COVID situation. Key factor in presenting to hospital is it should provide the opportunity, as per NICE guidelines, for a biopsychosocial assessment. And in many ways, our study of self-harm will look at covering many of these domains that are covered within a good biopsychosocial assessment. And therefore, we can bring this data together to gain the understanding. We did, though, already also study the impact of the assessment itself. And we found that having had a biopsychosocial assessment, even if somebody does repeat, will increase the time between episodes. Having a biopsychosocial assessment will reduce by 40% the risk of further repetition. And we also found that having a biopsychosocial assessment also reduced the chances of future suicide. So not only is this a chance for the person to tell the story, which might make a difference, not only is it the opportunity to gain information and data that may be helpful in the broader context, but also just having the assessment in itself makes a difference. So therefore, we need to be ensuring that people who are attending hospital are encouraged to attend hospital, and when they're there, receive the assessment. For some reason, we seem to not always take seriously all methods of self-harm. Some seem to figure within our profiles as requiring more attention than others, particularly related to our perception of future risk of suicide. This needs to be questioned quite clearly. Quite often people underestimate the importance of self-cutting in terms of future risk of suicides. And here we have two of our papers that have highlighted that in fact those who presented hospital with self-cutting are more at risk of further self-harm and indeed more at risk of future suicide. But sadly we find that those presenting at hospital with self-cutting are the group that's least likely to receive the full biopsychosocial assessment. Paracetamol overdoses are very common, but they need to be taken very seriously. Also acknowledge that any level of overdose requires attendance at hospital to be screened medically and then to receive an assessment, although we do note here the numbers who consume larger quantities. And also what's interesting is in younger patients presenting to hospital, they'll be more likely to be taking pure paracetamol in overdoses than any other group. So we do need to take paracetamol overdoses and self-cutting very seriously. Okay, let's just think briefly about some of the major impacts about COVID and what we know in terms of risk factors for those. First of all, in regard to employment and deprivation, we know those who are in a more deprived area, those that are having problems with employment, etc., are more likely to be self-harming, and the risk of suicide as well is increased in these groups. So we need to be mindful the impact of COVID on things like employment and deprivation are in fact risk factors in relation to future self-harm. Lockdown and the current restrictions mean that people are much more closer together. Therefore, if relationship problems are going to occur, they're going to be more likely to be occurring. And we note that the final precipitant of most self-harm acts, and indeed many suicides, will be a relationship problem with partner. We also, in one of our studies, highlighted the problems in regard to abuse within settings as well, and the link with self-harm. And finally, lockdown and a lot of the situations will have increased the level of loneliness and isolation that people will be feeling, or perhaps areas of entrapment. And we use one example here from the World Health Organization to highlight the impact of that. But also within our study, we have found that living alone can be a risk factor, and the lack of support and loneliness factors, particularly in older adults, can be quite significant. In regard to COVID itself, we're undertaking 2 studies to try to understand what that might be about. Our first study is monitoring of assessed cases that presented in 2020 compared to those that presented in 2019, and what profiles there are in regard to those presentations. The second study we're looking at is when we're asking clinicians who have seen and assessed somebody who's presented during this time in hospital to report on if they found that the COVID situation played a part in this attendance, and to try to understand what that might be about. Mindful that as COVID changes and its impact, so may be the influence of COVID on the self-harm presentations. So what have we found so far? Well, first of all, we found a reduction in presentations pre-lockdown in 2020. In fact, the biggest reduction occurred to start with in the week prior to lockdown, and then continued to be a reduced presentation during the lockdown period. Acknowledging that within A&E settings, other hospital-related presentations also experienced a very similar level of reduction, and we may want to debate and discuss later what that may be about. When we compared raw figures from 2019 to 2020, we were able to see the significant drop in self-harm presentations year by year, comparing years, each of the 2 years. And interestingly, the greatest reduction was in females under 35 years of age. And I think we're trying to develop our understanding about methods as well. There may be some changes in the pattern of hospital presentations in regard to the methods that people are using to self-harm. And these results might not be what we originally might have anticipated being the situation. So for the whole of this presentation, we've used predominantly findings from the Multicentre study, apart from 2, one from Mike Dennis and from the World Health Organization, in order to back up what we've got here and what's around. So I now just want to bring this to a close, and Caroline will present her picture of self-harm from a more community-based perspective, and then there'll be the chance of us talking through what we're around. Okay, thank you for this. Bye then.
Thank you very much for that, Keith. Apologies that some of you were struggling with the sound, but as I said in the chat, we'll be getting this all subtitled so that when it goes up on our website, it will be all fine. You'll be able to hear it or read everything. So now I'm really delighted to welcome Claire Dixon, who's Training Service Manager and Specialist Trainer for Harmless.
Thanks, Penny, and thanks, Keith. So yes, apologies, I am indeed not Caroline. She's unfortunately not able to be here this morning, but my name's Claire, and I, as Penny mentioned, I manage the training service around self-harm, suicide and mental health for Harmless. Just a brief introduction to our service. We're a user-led self-harm and suicide prevention service, so we do sit in the community third sector, and the picture of self-harm presentation through COVID that I think a lot of us in the third sector have seen is quite the opposite from the statutory sector, especially if you're in a healthcare setting. So I'm going to ask Emma to move forward the slides as we go and give you an idea of what we have seen at Harmless since lockdown in March. So 2 really important figures that we have seen. We compared a lockdown period versus a comparable period from last year. And one key figure that we have seen is that we have far more people who have been in touch with us. So we've actually seen a 200% increase in service demand. And for us, that means enquiries that often go on to referral points. And that is a huge, significant increase. With our existing client base, we've also seen an additional requirement for support and that need has kept increasing as lockdown has changed. We know that we're predominantly working in the East Midlands physically, and we have different pockets of local lockdown which are impacting people more significantly. So on average, we've seen a 13% increase in our existing client base requiring more support in between their typical usual appointments. So moving on. What did we do? Well, very quickly in February, March, when lockdown was on the horizon, we knew that we needed to get a response ready. We made sure that we put everything in place to retain a fully operational self-harm crisis and bereavement pathway, but we made adjustments for the remote way that people would need to access our help. With our crisis pathway, we've now very quickly implemented a text service for our current clients to get in touch with us in between appointments. And we wanted to know more, to listen to the user voice really in what they were telling us about their experiences of lockdown and self-harm. So we developed a public survey, which we sent out in July, and we had just over 140 people get back to us to let us know what their thoughts were. So moving on. A couple of things that we found. Number one, we were able to quantify a bit more clearly that increase in contacts. So April alone for us saw 4 times more email inquiries than February and over double the amount of inquiries than we saw in March. So as lockdown rumbled on, the inquiry numbers for us month on month were growing. This is just email inquiries, but obviously we also have inquiries through other means, through Facebook, Twitter, phone, and potentially face-to-face, people just sort of anecdotally getting in touch with friends who are aware of the service. Direct referrals from agencies did decrease in April compared to March, but we expected that might be due to reduced capacity of healthcare services in their ability to respond directly to people. Okay, moving on. Another thing that we found, and obviously this is just a snapshot from just over 140 people, we were asking people about their episodes of self-harm during lockdown, and the most reported shift in what we saw as an increase in frequency was from those self-harming between 1 and 2 times a week up to 3 to 5 times a week. So that seems to indicate a real-world increase, certainly for the people who responded to our survey. Just over 18% of people responded that they went from no self-harm per week prior to lockdown to actually starting to self-harm during lockdown. And that might well be those individuals who were in recovery, as Penny was mentioning, who were actually finding things quite difficult without access to support. So moving on. A couple of more specific figures, I suppose. The 2 figures here that decrease are people self-harming not at all or relatively infrequently. And the significant increases we saw were again in those who were self-harming between 3 and 5, 6 and 10, and over 10 times a week. That bottom figure hits pretty hard. So what we saw was just over 230% increase in those reporting self-harm, more than 10 episodes a week. So moving forwards. So one of the things we wanted to find out was, are people avoiding services now, and are they avoiding them more than they were prior to lockdown? And this seems to indicate that that definitely is the case for those who spoke to us through this survey. Almost 2/3 of people responded they don't ever ordinarily seek medical treatment for their self-harm, regardless of the current virus, but actually 40% of our respondents said that they have actively avoided seeking medical treatment during lockdown for their self-harm when they have needed that medical support. So there is a very real shift here in people actively avoiding medical treatment. And we wanted to find out a bit more about the reasons why. So moving forwards. We asked about GP avoidance and emergency department avoidance. And here we found that just under 70% of respondents said that if a need arose where they did need medical intervention as a result of their self-harm injuries, they would avoid going to a GP, and they would also avoid going to a hospital. And that's obviously concerning, because these may have been people who previously would have presented to medical healthcare settings. Okay, moving forwards. So reasons for avoidance during lockdown. 2 significant things came out here around not wanting to burden services and perceived stigma. Sense of burden and stigma are massively prevalent around the issues of self-harm and suicidal crisis as well, and mental health more generally. We knew this already. So as Keith was saying, you know, we're building on what we've already know, but actually we've seen an increase in all of those things during lockdown. So 3 out of 4 people didn't attend services for medical treatment due to that fear of burdening services and due to perceived stigma. And some of the comments we received were that people would feel stigmatized in healthcare settings, not understanding them and their presentations, fear of judgment. One respondent really sadly said, what's the point? You know, what's the point in going to them? And another respondent said partly coronavirus and partly prejudice and disrespect from staff and guilt at being a bother when it's self-inflicted. So these are very real points of distress laying behind these very real reasons why people are avoiding services during lockdown. So moving on. A question that we did ask was, if you would be worried about seeking medical treatment due to the virus, why? What would this be specifically because of a fear of contracting the virus or a worry about overwhelming services or other reasons? And overwhelmingly, people responded that they were concerned that they didn't want to be a bother and they didn't want to burden services that were already stretched. I find this particularly heartbreaking. These are individuals who harm themselves, who may need, they may want, and they certainly deserve support. And they find that and can find it difficult at the best of times, let alone during a global pandemic. So just to pick up some comments in the next couple of clicks here from people. Somebody said, depending on how serious, I'm certainly less likely to get help now. I'd feel bad for using NHS services while already stretched, and I'm scared of being called selfish by people for taking up much needed NHS resources during COVID-19. Somebody else said, sadly, staff attitude is nasty at the best of times. I wouldn't want to face that now. So these are a group of individuals who may already feel a sense of stigma and burden, who are perhaps feeling it even more heavily now. And we know that they are presenting less at medical services, but again, what we've seen reflected in the number of people coming to us as a community service has been significantly higher than we would ever have seen in the past. So moving on. I just wanted to pick up really a bit of our client voice. Really, as a user-led service, we're quite keen to give these anecdotes a bit of weight behind them with real people, just to bring to home the fact that behind these numbers are individuals in distress. So this is an example of one of our clients who was already engaged with our support services and had gone home for Easter. They're a university student here in the East Midlands. They'd gone home for Easter just prior to lockdown, and then lockdown was implemented, and they remained there then between March and September due to the lockdown and the way that the virus was affecting universities. They found that obviously they were away from their friends at university. They had less day-to-day structure in their life, and their social interactions were hugely decreased because of the lockdown restrictions. They were locked down in their hometown with their parents, and unfortunately for this client, their experience was that their hometown had been where they historically experienced sexual abuse, and that past trauma was very much brought into the present because of the physical environment they found themselves in, which hugely increased their sense of rumination, their suicidal thinking, their fixation on their experience of trauma, and their self-harm urges were incredibly strong and growing. And what we saw for this client was that they had an episode of self-harm. So albeit the frequency wasn't significantly huge in number, it was significant because this client had come to self-harm 1 year after their last episode. So their distress trajectory was quite rapid through lockdown specifically. So what did we do? Going on to the next slide. One thing that we do quite well, I think, in community services is respond really flexibly to need, and that's certainly what we did for this client. We supported through different remote means. We asked, what would you prefer? Video calls, securely, phone calls, texts, what would work best for you? And for this client, that flexibility and provision was really gratefully received because they were incredibly anxious to do video calls. So we gave remote support here by phone and by text. And we made sure that depending on that need, wherever it wavered, wherever it had peaks and troughs, we were there to respond to it as quickly as we could. One thing we did very practically was review their safety plan. And through the whole process of those months between March and September, we saw this client's suicidal thoughts significantly decrease, and so far to date, no further self-harm. And really that just shows that we need to listen to clients and what they're telling us and try and implement those changes in line with what they need very quickly, wherever possible, especially during a crisis like this. So moving on. What next? So there are a couple of points here that I'm going to bring up. And one of the things, speaking from a third sector service, is that we know this is where people are at the moment during COVID presenting. So there's an issue here in that where people are presenting is not resourced appropriately, and a heavy reliance at the moment on the third sector is not necessarily sustainable. It's not going to survive the COVID crisis with limited funding streams available. So a key point for us and other services doing similar work is we need more broad investment in self-harm prevention services. And we can especially see, and I'm sure we will through further research, through the Multicentre study and services like our own and through NSPA work, that Covid-19 has had a significant impact at a time where we know self-harm and suicide look to be increasing and where people are sort of voting with their feet and going to the third sector. But when this sector is under such strain, we do need to have another revisit and a look at sustainable responses to need before it's too late. And what we can all take a part in is continuing to engage with our existing clients and the people that we know are in distress to ask what they need and what they want, and wherever possible to provide that, to give them some hope for the future. So then moving forward to that last slide. These are our details. So if you do have any further questions specifically for our service, here's where you can get in touch with us. Thank you.
Thank you very much, Claire. Really fascinating to hear the difference between the experience of statutory services, A&E departments, and what was going on in the voluntary sector during that period. I think one of the things that I'm really keen, I'm just going to usurp everyone else because I get to be the chair. One of the things that I'm really interested in is you guys are quite focused on lockdown, and obviously we then had the easing of lockdown and now more restrictions coming in, tier 1, tier 2, tier 3. How has it been sort of from the end of lockdown and now going into this next phase?
Keith, do you want to go first?
Yeah, okay. I think we've seen changes that have been happening. Some of them have been a little bit more subtle than others, because some of the features like the loneliness, isolation, etc. may have been the greatest for some during lockdown and less when things are starting to be eased. But I think the concern is still there that the stressors are around. They're the sort of stressors that we knew about were risk factors, and in fact they're increasing. And for those that had those kind of risk factors previously, they're obviously struggling quite a lot, and many in the population are now facing things that they would never have expected to be facing. So it's going to be changing, but also the consistent things are there as well. We mustn't forget the stuff that we knew and the stuff that's important to be doing, and not get over concentrating on it all being about COVID. COVID has brought to our attention a lot of the things that are difficult, but they were there before, and the things that we needed to do about them before, we still need to be doing now. Penny?
Yes, go on, Claire. I'm sure you have something to say as well.
Yeah, I think what Keith said is kind of spot on. We've known about these different risk factors and triggering events and times of difficulty in relation to self-harm risk for a really long time. I think everything's just been kind of compressed for a lot of people. So one of the things that we saw, particularly with a younger cohort, so kind of university age students, was our Nottingham office. We're in a university city with 2 unis, and everybody was maybe here for the first time in their, halfway through their first year, and then they all had to go back home. And I can't imagine how difficult that would be for that group of people, for instance, having to kind of, have that massive transition and then that transition kind of undone. And I think from what we've seen, we've kind of seen this increasing need during lockdown, but also since as well. So one of our areas of work is Leicester and Leicestershire. They've been in local lockdown for more than 100 days now. So there are those everyday concerns and worries. And I think people are just sat there with them in a much more intense way. If you think about a practical example like financial difficulties, for instance, how many people have been put on furlough and they've now been made redundant, or, you know, anecdotally, I know a lot of people that's happened to, and it's perhaps not surprising that coping mechanisms that have worked for them in the past have come back into the picture for them. Thanks, Penny.
Thank you both. So we've got some great questions in the Q&A section, so I will just start with those. And some of the first ones, unsurprisingly, are in response to your presentation, Keith. So firstly, is the psychosocial assessment standard across A&E services in the UK? And actually someone else has just asked us sort of a second question to that, which is that assessment completed with young people, or is there a different assessment for them? Keith.
Okay. Standard across the US, there's no format that is absolutely written down in a sheet that this is what you definitely follow and this is what you're recording. However, for all age groups, what should be being followed is the NICE guidelines. The NICE guidelines on self-harm, which are actually being rewritten as we kind of speak, as it were, are very, very clear about understanding not just the recent events and precipitants and recent stressors, but the overall background factors as well, the person's history, their life events, their coping strategies, as well as assessing, you know, is mental illness features there or not, as well as physical bits. So there should be a fairly consistent approach in contact with A&E departments by liaison teams particularly. And that should be very similar for young people as it is for the adult population, with the increased emphasis with the young people about the involvement of their carers, their parents, etc. So it is effectively standardized, but it will look very different as an individual encounters somebody. But hopefully that's what should be being covered. And liaison teams are trained in those assessments because it's the predominant part of the work that they pick up coming through A&E departments. In our A&E department in Derby, that's around 2,000 presentations each year. And effectively all of those should be being referred. They don't manage to all get an assessment, but they all should be being referred. Penny.
Yeah, thanks, Keith. And I think one of the things that came up in the online conversation is different A&E departments' approach to people who present with self-harm. And so there's some really lovely work being done in different areas on specific teams and individuals working specifically with those who present with self-harm and providing spaces where they can be supported with their emotional and mental health, as well as kind of the physical presentation. So do have a look, because there's some lovely work out there. The next question, and I think, again, this is kind of more for you, Keith. Are you aware of any plans to log or record within studies differences in type of lockdown and the impact on self-harm with the introduction of tier 1, tier 2 and 3? And will there be notable differences in outcomes for people living in the north and in the south?
Okay. I think it's going to be quite tricky to do that in that level of detail. We will be able to look to some extent over a time bit because we can monitor what times things are occurring. Now, currently the Multicentre monitoring study of self-harm only actually calls a national study or England study, but it's only 3 places. It's Manchester, Oxford and Derby. But actually that's quite an interesting spread of mixtures of communities and mixtures of effects of COVID and the various lockdowns. So there may be the possibility of doing that, but it's very hard. It's also very hard nationally, which maybe picks up on another question, to get a consistency of data collection. Yes, there are means of trying to do all of that, but when we've looked at it in detail, there's so much variability. And at this time when we're needing to find things out now, it's really hard to actually get really consistent, reliable data. As we know from our suicide prevention work, real-time surveillance has been a goal for us for a long period of time. But to get that quality of data that accurately reflects what it is that we're wanting to study is notoriously difficult.
Yeah.
Penny.
So this is an interesting question from Tanya. When presenting to A&E, can one assume that these presentations are only when the self-harmer feels they need medical attention? For example, they can't stop bleeding. Can we therefore conclude that those who self-harm and would require mental health support are not receiving it via that route? I suppose that's more about your kind of work, Claire, that those people who don't present to A&E.
It's really tricky. Most people, from what we know through research, don't want to reveal their self-harm for a number of different reasons, and they are reluctant to present to services anyway. And historically, we've been quite bad. The Royal we've been quite bad at treating self-harm holistically. So we've separate, like Keith was saying, we might have separated out a physical injury from the emotional distress, because if you present to ED, for example, you are presenting for a very physical reason, but then that is the opportunity to do that psychosocial assessment. So it's vital that we do that. I think, there are people who will be in the community who perhaps do need medical support, but they won't come forwards. They won't come forwards and seek it. And, historically, we know that is predominantly because of the guilt, the shame, the stigma. And that is no less now. In fact, it's probably even more so during COVID than any other time. So I think it's just about kind of seeing the overall picture and remembering that, just like Keith was saying, you don't have to have significantly physically injured yourself to be, that in huge amounts of distress. The physical injury does not match the level of distress, and nor does the method. And I think that's something to always bear in mind, for sure.
Thanks, Claire. Keith, did you want to add anything on that?
I'm going to say slightly, potentially maybe some controversial bits with all of this. Without doubt, Claire, I highly support the idea that the level or intensity of the cutting is not a measure of the level or intensity of the despair, and the importance of coming to A&E is to be medically screened first. So, is the tablet safe? What's that all about, and what have you? But provide the opportunity for the story to be told, for the biopsychosocial assessment. But I do think we too readily jump to the solution rise within mental health services for this. It was interesting looking at Claire's slides. The stuff that was making a difference wasn't necessarily the root reason for going into mental health services. I have no hesitation of saying when there are mental illness features there that require treatment, that should be managed by the mental health services. But actually the stuff that makes the bigger difference is the compassionate responses of friends and family, the not taking, by taking it seriously, by not undermining what the person is feeling, by making sure those stressors that have led to this level of despair are being looked at. So things like housing, finance, jobs, etc., which aren't necessarily the predominant involvement of mental health services. So it's very easy to say, oh, this is mental illness, therefore it needs to be dealt by mental illness services, or very easy to do the opposite, to say we're not taking this seriously and therefore it needs to be dealt with by family, friends and third sector. There is a ground in between that we need to be working together, but not one group seeing exclusively the other group as being responsible for it.
Yeah, go on,
don't mind me jumping in on that. It's I think what you're saying is absolutely spot on. There are many individuals who will self-harm and be in incredible amounts of distress, but they don't have a mental health diagnosis. They don't have an underlying mental health need. Is there distress? Absolutely. Do they meet thresholds for service provision? Possibly not. And that is often where we will see that we are acting as if that, acting in the third sector like that safety net for people who maybe don't quite fit in other places. It's one of the reasons, like you said, Keith, that we have, a team of specialist therapists, but also practical support officers to try and kind of mitigate any of those risks for the person, because it does come back down to that compassion. And, time and time again, we'll hear at the end of perhaps 2 years of therapeutic support with an individual, not that it is, this adapted CBT technique tool that, worked effectively well. It was the fact that someone was there when they said they were going to be there. They made me a cup of tea. They allowed me to sit and talk about whatever I needed to say. And sometimes they allowed me to just sit there in silence, just be present with somebody, because that's what I needed. And I think that's that foundational bit that for many people through experiences of self-harm, is not there, unfortunately. It's missing.
And it was certainly something that came up in the online conversations, was the concern that sometimes a GP will refer someone to mental health services, and mental health services won't necessarily think actually this needs mental health treatment. but they don't necessarily know what services are out there in the community. And so for lots of the people that we were talking to earlier, it was, how do you build those links so that actually GPs know about community self-harm support services, or mental health services know about the community self-harm organisations that they can be pointing people to, where they can get that other support. Yeah, great, thank you. So there are quite a lot of questions here. So there is some stuff around messaging. So are people aware that services are still open? And also, do you think there needs to be more messaging about letting people know how to access services for self-harm and suicidal ideation? There's lots of stuff around from the government around life-threatening physical health issues, but not necessarily the same for mental health issues. Keith, do you want to start with that one?
Yeah. A really important message is that mental health services are not shut. They are still there, but they are operating in a very, very different world and environment than they've been before. And inevitably, the face-to-face contacts and groups and various other things have been decimated by the COVID situation. However, on the positive side, things have happened really very quickly in terms of online supports, crisis lines, etc. And maybe the messaging does need to be out there that, first of all, don't be afraid of contacting, don't feel guilty about contacting. There are 24-hour, 7-day-a-week services out there, which we didn't have before under mental health services, but we do have now in basically, I understand, all areas of the country. I know we have it here in Derbyshire. So it's going to be tricky, but it is there. I must admit, my feeling is it's really important for the person who has self-harm, particularly early on, before it becomes such a routine way, to have the opportunity of a detailed biopsychosocial assessment to understand their story and work things forward, than wait until it's too tricky. And, to feel that they're a burden on A&E or their GP, because both those services have actually had less self-harm presentations than they had before. Now, the flip side of that, which may be again related to one of the other questions, is maybe we're underestimating individuals' resilience, but community resilience, but also the power and importance of being more community orientated, of being online and talking to other people, of feeling okay to ring organisations like Harmless and the others. Because again, in some of your other calls, I picked up some of the other organisations are having increased volumes of calls, but not necessarily specifically about the area that they were kind of set up to cover. So maybe people are seeking help more, and maybe, we are finding different ways of coping that may be advantageous, as opposed to this all being a worry story and everything's bad that's there. Yeah. Penny.
Claire, did you want to come in on that one?
Yeah, I think just in terms of kind of messaging and letting people know where we are and who's open and all of that jazz, I think there's historically, in the third sector, we work very hard to shout, to let people know we're here anyway. So during this time, it's been particularly challenging, I think. I would say one of the tools that we use quite heavily, like many people do, is social media. So we've tried to get out as many mail outs, as much contact with people via social media as we possibly can do. And one of the things we did to try and reassure people, especially our own clients, very early on in March, was every single day we would upload a quick hello and a debrief video on our Facebook Live at the start and the end of every day. And I think it's just those small things that every service could be doing to just go, hey guys, like, we're here. Don't forget you can get in touch with us and you deserve to get in touch with us. And, please don't let anything be in the way of that, with the reality that there will be many things in the way of that for a lot of people.
I can see from some of the chat, and I think from some of the questions, that we've got people here attending the webinar who might be not specialists in mental health services or specialists around self-harm, but are working with people who they know are self-harming. And so just questions about how can you respond in a supportive way, and what would the best response be? Claire, do you want to start with that one?
Oh, how much time have you got? Number one, tell them thank you so much. Thank you for being able to share this with me. It's a real privilege that you've actually been able to have a chat with me openly. Number two, do not judge them. Don't put any of those stigmatizing labels like attention seeker or manipulator, or even the term self-harmer. They're more than their self-harm. They are an individual person, and let them know that even if the next thing out of your mouth is, I don't know how to support you, I've got no idea what to say and do next, but I am here and I want you to keep being open with me. Let's see where we can get some help and support. that's the foundation of it all. It's just active, open listening. Listen to the person's story, listen to what is happening for them, validate and take their distress seriously, and don't just reduce it down to let's see the physical injury, because that doesn't tell us much about the full picture of the distress behind the scenes.
Yeah. Keith, do you want to add anything?
Okay. If the person's revealed that they've overdosed in a relatively short period of time, the initial response is actually going to hospital, because we don't know what's safe and there. We need to make sure the person is safe. But how you communicate that and how you do that picks up at Claire's points. You know, don't be judgmental. Try to be provide some space to talk and some opportunity. Yes, it's okay to say I don't know, but actually most of us do know what distress is about. We do know what we struggle with. And actually we have, you know, resources that we can be thinking about and what might be the sort of things that the person might help. And again, try to not be over adventurous. You know, if somebody is struggling with something, okay, is there a tiny little bit that can maybe done to help? Yeah, how do you eat an elephant? But, you know, bite sizes at a time, as it were, or just doing a little bit, because the balance between the distress and despair can be tipped by just a little bit of a weight on the positive side as opposed to the negative side. So yes, you know, stigma is a major barrier that gets in the way. And also in some ways not feeding the negative perceptions about services, you know, or you don't want to go to A&E because they might not treat you seriously. You know, we feed in very easily. We don't mean to, but we need to be say, you know, okay, I hope you'll have a good experience, because many people have experienced it. If it doesn't go okay, come back and talk to me about that and what that was there. But, you know, taking it seriously, believing what the person is about, and not to be measuring how good or how difficult things are for them by what they've done, how often they've done it, or the intensity of it, because that doesn't measure what they're really all about. And I really worry, particularly with cutting, when people try to set targets, oh, coming next week, not try to harm. Well, actually, it's going to happen more, because you're focusing on the behavior, not what's causing it. Self-harm, in some simplistic way, is only a symptom. We need to be understanding what's it a symptom of for that person. What is their distress and despair that's there? So I'm not sure that helps anybody who's dealing with this without that background, but be you, be human, be compassionate. That will make the biggest difference. Penny.
Thank you both. And one of the things that I know came up during the online conversation was the if someone presents at their GP and tells the story, and then the GP refers them, and then they tell the story again, and then they get referred to somewhere else, and this sense that you're sort of expecting someone to retell and relive some of the most difficult things that they're going through that are at the cause of their self-harm, and to find ways to simplify that process to, I think someone was coming up with a kind of little credit card size, this is my story or something, so that people don't have to keep retelling, because that is actually can add to the distress. Go on, Keith, you look like you're...
I'm going to be critical of services in a way that they're almost risk averse, and by being risk averse, they feel they've got to know everything that they've found out in order to understand what it is they are or aren't doing. And that, for the service user, the patient, or whatever, is a terrible situation. We ought to find much better ways of being able to pass information out. I used to find when I worked in A&E, I'd be wanting all the time to say, look, I know your story that you told somebody yesterday, and maybe we can just pick up from where yesterday was on to today, because going through it time and time again isn't necessarily for most people a beneficial thing. But stuff like, you know, having stuff written down, having safety plans that clearly highlight what the person is or isn't able to be doing or wants to be doing to take things, to have those to take with them. You know, with the internet and with media things, there are very rich ways we can do it. But services are still very siloed overall, and it's going to be a long time before it really is a truly integrated and passing on bit. Even within one service, a mental health service, if somebody moves from one team to another, they may be experiencing this. So again, we need to make sure that people are aware of that. It's not that we're just going to force them to tell their story because we want the pain to be experienced again and again. It's the way in which those services work. We need to be changing it, yes, but that change is going to take a long time. Penny.
Thank you. Claire, did you want to add anything in on that?
I think just to echo everything that Keith just said, really, to have it written down in your own words can help you. It can facilitate that level of understanding of your own experiences as well as anything else. So, writing things down or drawing things out or whatever can be an incredibly cathartic, therapeutic process in itself, to understand your own degree of self-harm. But, the reality is we might ask people questions like why, and somebody who self-harms may not know the answer to that question. It can be really, really hard. So I think, yeah, if people are able to just kind of do exactly what Keith said, take it from today, what is the person coming to you with right now? What is it right now that they need and want from you? Do we have to dig 25 years past in their history, for example, to know what they need right now? Because those needs are going to be fluid. They're going to change day to day. And I think, yeah, it's just worth taking that point in the context of what is the person living with right now.
Yeah, thank you very much. We've got lots of questions, and we aren't obviously going to be able to answer all of them because we're really nearly out of time. So we'll have a look at these questions afterwards, and if we can, we'll get back to you with answers for those of you we've got contact details for. Finally, is there anything, Claire or Keith, you wanted to say to the vast audience of 300 and something people out there around this issue at the moment?
Keith?
Take so seriously self-harm. Take seriously people's thoughts about self-harm in the same way as we take suicide prevention seriously as well. It's not the poor relation in terms of suicide prevention, because many times that what we can do early on, what we can do to help people maybe not progress to actually harming, or what we do when they have, can make such a significant difference for them. And this time is not all bad. There are lots of useful things that have been happening, lots of positives that are there. Yes, we know that some things will be quite tricky and difficult, but that being able to talk, being able to contact, being taken seriously is very, very vital. And in fact, I think it's happening more now than it may have been prior to the onset of COVID. Thank you, Penny.
Thank you. Claire?
I think I would just remember that if you're working with people who self-harm, that recovery, it sounds really cheesy, but it's a journey, it's a process, it's not a destination. If people are going backwards and forwards with their frequency or severity of injury at the current time, perhaps that's not surprising. Don't forget that people who are using self-harm are trying to survive. They're trying to get through these difficult times, and that is an amazing source of hope. Actually, it's amazing desire for resilience moving forward. So hope is always there somewhere. We just have to know how to find it and how to look for it. Recovery is always possible, and the one key thing you can do is don't judge people, validate their experiences, take them seriously always, give them hope that things can get better, and give them permission to celebrate every tiny victory. If they can get out of bed, if they can brush their teeth, if they can sit with their urges to self-harm for 5 seconds longer than usual, they are all things to celebrate. And that's what we need to help people to try and see in their recovery.
Great. Thank you both so much. Thank you everyone for joining. As I said, we'll make the webinar live on our website with subtitles, and we'll email you all as soon as we've got that live. So thank you everyone. Have a good weekend, and we'll be in touch with more information when everything's live. Bye.